from MDS to secondary AML, the various mechanisms, obviously the most important thing would be the clonal evolution, right? From the MDS stage to the AML stage. And in fact, it's not only the epigenetic regulators that accumulate, it's also some of the mutations that confer a proliferative advantage, like FHKCP, right, that may occur at evolution, or the acquisitions of p53 mutations, right? These are common sort of tumor suppressor gene mutations. So these are some of the common mechanisms of progression from an MDS to a secondary AML. I think it's more sort of a accumulation of genes that confer proliferative advantage, and also acquisitions of these mutations in the tumor suppressor gene. So these are the two common sort of mutational profile that we see in patients who progress from an MDS stage to a secondary AML stage. And of course, this is also complicated by the treatment that they receive. Right. One of the commonest treatment that we see in patients in higher risk MDS would be the use of hypomethylating agents. Right. So this treatment would also induce certain epigenetic changes, perhaps both on the DNA methylation changes as well as in the RNA methylations. So I think these are two things that we observe. And certain patients, they might be treated with chemotherapeutic agents. Say, for instance, certain MDS EB2 patients, they would be treated with chemotherapy. And these would also induce a secondary changes that result in transformations. And one important thing is that most of these patients with MDS who progress are those who carry high-risk mutations, like H6L1, RUNX1, TP53, or small clones of FHKITD or MLL, partial tandem duplications, and so on. So with treatment, basically these small clones that harbor these genetic alterations are not cleared, and they just evolve and accumulate. So that also accounts for the reason why these patients progress.